if you give it 5-10 seconds, and then you can get underway. Ready when you are.
Brilliant. Okay. Thanks very much. Thanks, Ryan. Thanks to everybody who's joined for our July governing body meeting for the Vale of York CCG. This is being live streamed on YouTube and will be available on the website as well. And unfortunately, we're not face to face this time. We're still virtual, but let's see what happens for the next time. So just going into some notes. We haven't got any questions from the public today. And we have got some apologies from Sharon Stoltz, Steph Porter and Ruth Walker. And I know Sharon Stoltz was meant to be with us today, but she is taking some urgent questions about the COVID rates, so that she can't be with us today. So we completely understand that, and it might be something that we touch on as we go through this morning as well. I'm delighted that David's been able to join us today, and David's on the Isle of Mull. So thank you, David, for taking some time out of your holiday to join us at the governing body. It's much appreciated. Okay. Although we'll probably get into this with a bit of any other business, and Phil Meta might touch on it, but the CCG constitution does state that we'll hold 6 meetings a year in public, but we might have to look at how we look at that in our transition towards ICS in April 22, and how that is looking. What's the best way to do that? So it's something that maybe Phil Meta might want to touch on a bit later on, and we'll come back with a proposal to this meeting later in the autumn. Our AGM also, we're hoping to schedule that for the afternoon of the Thursday, 16th of September, and the likelihood is that'll be a hybrid of a virtual meeting streamed, and also some people there in person. Okay, so I think that from me is that bit. So just getting into my agenda. So apologies when I flick around. So next bit is the declaration of members' interests in the meeting. Again, if anybody has any extra declarations that they need to tell me, please do so. We'll note, as we've done for the last couple of meetings, the extra roles that members of this governing body have, as we've done before. So I hope that's okay for everybody. But again, if you do have anything that we come across, please do declare it, and we can talk about it and sort those interests out at that time. I hope everybody has been able to see the minutes of the meeting held on the last time on the 6th of May. We have not scheduled any sort of interruptions from chief nursing officers this time, so I think Michelle Carrington, you can rest easy that there's no, or anybody else on the call, there's no surprises. And also, if the notes are acceptable for everybody, the minutes to approve, then the matters arising, I've noticed that those are ongoing, and will probably be picked up within the body of this meeting as well. So if anybody has got any issues with those or anything to raise, please do it so now. No, fine. Okay, so that means that we can go straight on then to the accountable officers report, and that's over to Phil Meta.
Thank you, Nigel. Good morning, everybody. Schoolboy error, managed to have myself on mute. So as Nigel said, the intention this governing body is for a stock take. So in line with that, I'll make my comments that are referenced in the accountable officers report relatively brief. The financial position for the first half of this year is now starting to look challenging. There are a number of financial risks starting to surface. We'll hear more from Simon Bell about that later, and we also still await clarity on how the second half of this financial year is to be resourced nationally. So more on that from Simon later. The Finance and Performance Committee will continue to keep that under regular review and report back as required and as appropriate to this governing body as and when it meets. With regard to service delivery and recovery, we continue to see demand which is unprecedented in some areas. So the demand for mental health services for all ages continues to go beyond the forecasts that were originally made regionally, nationally and locally. We are doing everything that we can across the Vale and more widely to transform the way that services are delivered to start to meet that demand. We may hear more about that later in the meeting. In the acute sector, we are seeing a demand for urgent and emergency care response, which again is particularly high at the moment. We may hear from Michelle more about the pressures in emergency departments later, and particularly respiratory pressures that we're seeing in children and young people. And GP colleagues on this governing body will know that pressures in primary care continue to grow and continue to be difficult to accommodate in the current context of the COVID restrictions that we are working to around social distancing and infection prevention control. So the whole of the NHS across the Vale of York is under significant pressure as we enter into this summer period. Moving away from the local position, nationally, the move towards creating integrated care systems is still pressing ahead. Within Humber Coast and Vale, that got to the point where there's an intention to have in shadow form the ICS governance arrangements and operating model in place and working and up and running from November of this year in readiness for the new arrangements from April 22. In part because of that, as Nigel mentioned, we would like to agree in this governing body how many more meetings we think would be right and appropriate to hold for the remainder of this financial year. During that period, if we are to reduce the number of governing body meetings, what we will make sure we do is that we continue with the committees that work on behalf of the governing body to ensure good governance with regard to our financial controls and our quality and safety monitoring of services, and to make sure that we continue to adhere to all of the statutory duties of this organisation. So we may have a way of working in the next 8 or 9 months that is perhaps different to that we've experienced before, but we will all need to be comfortable with the level of rigour that we apply there as we transition towards the new ICS operating arrangements. One of the outstanding areas just to note in terms of that transition is that we still await what's being called the talent framework for staff, and it's that framework that will help us manage the transition for staff with regard to the HR framework that we would work to ensure that that's done in a fair, transparent and reasonable and appropriate way for all of our staff. So we continue to do what we can to make sure that all of our staff are reassured during this period, and we await that guidance, and we will act on that as soon as we are able to, and of course report back through our committee structure and governing body to make sure that you are assured that we are continuing to do what we can for our staff. I'll stop there. Nigel, thank you. Happy to take any comments or further questions from anybody as we go through the meeting. Thank you.
Brilliant. Thanks, Phil. I'll open it up for anybody. I just wondered, Phil, if I could just also say that we do have another protected learning time this week coming up. I think it's just important to maybe explain to people that are listening in about why that's so important, really, that protected learning time. And this one really is talking about practice resilience, personal resilience of practitioners, but also looking at different IT solutions for patient access. So it is a really important time for us to get together to share best practice. So we're making sure that we're doing the best for the residents of the Vale of York. So just wanted to highlight that. Anybody else wanting to come in on anything that Phil has said? I won't be able to see your hands because I don't think your videos are on from my point of view, but I'll be able to see virtual hands if anybody wants to add anything. Otherwise, we'll go. Oh yeah, Phil Goatley.
Thanks, Nigel. Phil, just a quick one. So we're still going to run the current committee structures. If concerns are raised by one or more committees, where would they go then if we're having less governing bodies? Will it go to somewhere in the ICS, or will it just go to the governing body? There'll just be less governing body meetings for it to go to.
Yeah, good question. Thank you, Phil. So as part of this, what we will do is we'll agree a protocol so that all of the committees can make sure that any issues of concern are escalated as appropriately. So, for example, that protocol would involve escalation to myself and Nigel, and consideration of what might be required in terms of an exceptional governing body or not. And for clarity, when we have the discussion, I wouldn't propose that we move to a situation where the governing body doesn't meet, but rather than meeting monthly, I think being in a position to meet every 2 or 3 months and being clear about why we would meet is probably an operating model that we should explore. And in between those meetings, as you said, we absolutely need a way. We need a protocol that all the committees can use to make sure that there's a prompt and transparent and appropriate escalation of any issues as required. So I think that will be part of the new operating model. Okay,
thanks for that, Phil. Yeah, I mean, the prize I don't want us to lose is that we've got to a situation in the CCG where we have, in my experience, pretty unprecedented levels of support and positive commentary from both internal and external auditors, and I wouldn't want us to give that up easily.
Thanks, Phil. And Phil, David.
Yeah, just very briefly, following on from Phil's point, what will the arrangements be for audit? It's probably too early to say in detail, but there's going to be a major transition, and where will internal and external audit? Is somebody within the ICS charged with ensuring that proper audit is still continued?
Nigel, I'm going to offer to not answer that question, if that's all right, and I'm going to invite the audit chair and chief finance officer to give that a bit of thought. Maybe we don't have to answer that immediately, David. It is a good point for us to be able to address in terms of assurance. So we can note that. I don't know whether Phil or Simon want to say anything about that now, but we could certainly come back to that.
I'll have 10 pence. The external auditor's view, I certainly think, will centre, as it usually does, around the statutory accounts. And they will take the view that the CCG, the Vale of York CCG, remains a statutory body until midnight on the 31st of March 2022. And they'll they'll act accordingly. So they'll very much have the view that, you know, nothing changes from their perspective until the CCG demises. Internal audit may well want to try and work across the transition, so they can be more flexible, and I'd expect them to be. They'll still need to provide the levels of assurance that they need to in order to not least underpin the external auditors and to provide us as a governing body with the assurance that they do. But they'll have a separate role in the transition, and then with the ICS as well. I'm sure Simon can say more.
Simon, do you want to come in?
Yeah, thanks. So not for me to comment on the audit committee's business or conduct, as they're independent of me and I'm not a member of it, but I suspect taking a balanced approach to how we report risks, as we have done over the past 18 months, is going to continue to be the way to go. In terms of transition, we're still seeing new information coming out. So released, when was it released? Probably in the last week or so. National guidance on the ICS operating framework, which has subsequently been translated into a local version of the same. Just a sort of one-liner in there that the ICS locally is not expecting financial arrangements in place to be ready for the 1st of April next year. So a year to go through of further transition around finance, which will be slightly behind the pace of other elements. So again, new information that we'll have to digest that will be relevant for the audit committee, but also this organisation and audit colleagues to plan through and think through. So still quite a live situation, I think.
Thank you. Thanks for that. Is that okay, David? Anything you wanted to come back on about that?
No, that's fine, Nigel. Thank you. Very complicated, but it's a work in progress, isn't it?
Yeah, and I think thank you for highlighting it, because absolutely that we need to keep these statutory functions live and understand where our responsibilities continue to be. So thanks for flagging that. Okay, if there's
Nigel, I'm just concerned that Ruth May's rocked up at Chief Nurse's front door again.
It's just not a governing body without that type of thing, is it? Oh yeah, Julie, did you want to come in?
Yeah, sorry, my virtual hand's not working, so I use the real one. Man, as always, is around our staff, and you know, I think the expectation was that in the documents we've just received, there might have been a little bit more meat on the bones here for them. And how soon are we going to hear something, just to try and start to reassure our staff?
Michelle, do you want to come in on that?
Hi, thanks. Sorry about the emergency knock on the door there. Wasn't even for me. So in terms of our staff, last week, staff received the information to say they have an employment commitment. And I think that's hugely reassuring for those people who are at below board level. And that the HR guidance, so we're still awaiting the HR framework, as Phil described, but the HR guidance not only said that, but to reassure them that their roles and their job descriptions are unlikely to change unless there's a real need to do so, at least in the short term. And I think that's helpful in terms of how we go forward, making sure that we've got, you know, that 80-20 rule of most things being in place as far as possible. And if that makes sense to do so, and then where it makes sense to do things together collaboratively, we will do so, and more strategically at the ICS. So I think that's been really helpful, and staff have told us that too. And then they've all received yesterday an individual letter to that effect from Professor Stephen Eames from the ICS.
Thank you, Michelle. That's really reassuring to hear. Thank you.
Phil?
Yeah, sorry, I've read the employment commitment a number of times, Michelle. Am I right in thinking it's only a commitment for the period of transition? What will then start to play in more substantively is things like COSOP and TUPE, because this is being couched as a transfer of an undertaking, isn't it? So TUPE will certainly be coming into play, and that will be the substantive legislation under which existing staff's employment conditions are protected. That's exactly right. TUPE applies for staff, and they will therefore all be employed by the ICS rather than the individual CCGs. So yes, you're absolutely right. TUPE applies, and therefore the protection that comes with it.
Great, thank you. And thanks, Julie, for flagging that really important message, because we've worked hard over the last number of years to get a secure base for our staff in CCG, and also around a big strategic plan for the residents of the Vale of York. So it's really important that we continue that and look after them as we go forward. So thanks for flagging that and responding, Michelle. Okay, so if there's no other bits on Phil's report, thanks Phil for that. We're now on page 22 of the agenda pack, and that's over to Michelle Carrington for the Quality and Patient Experience report. And this is to receive this report and a decision around for the governing body to accept this report for assurance and mitigation of key quality, safety and patient experience issues. So we're going to determine whether we're assured of the work being done to understand the support, the quality and safety of the Commission's services. So that's for the decision log. So over to you, Michelle.
Thanks, Nigel. So last time that the Quality and Patient Experience Committee met, we did a deep dive into primary care and medicines management, which was hugely helpful. For those of you unfamiliar with how that meeting works, is we meet regularly, and intermittently we have a deep dive. We've done mental health, for example, we've done end of life care, we've done dementia, and this time it was for primary care. And again, it's been more difficult for the CCG to get assurance over primary care because you don't have the usual quality markers in contracts which help you do some of that. You're reliant on your relationships and the information that primary care choose to share with you, and then also the regulatory activities such as CQC, and also really importantly what patients tell us. And so it is more difficult, but I think that we are much further on than we used to be around knowing how primary care was in terms of quality and safety. And I thank our primary care colleagues for that, for their transparency and the conversations that we've had over the years. So we did two things. We did a presentation around what patients are telling us from our engagement lead, Victoria Binks, and Health Watch are part of the Quality and Patient Experience Committee. And what was really helpful is that you will know that Health Watch have also recently done a report on access to primary care. And what they found really useful was to hear about all the fantastic stuff that happens in primary care and verbalise that too, that they didn't know that some of that fantastic stuff was happening. So it was a real pleasure for them to hear that and get some balance within that feedback, which they appreciated. So in terms of that end of year review, you'll see on the appendix 2 that our comms colleagues have helped us describe that in a very diagrammatically perfect way, really easy to follow, and unearth some real highlights for each of our PCNs within the Vale of York CCG. And just a few highlights for me is that, you know, we've talked quite regularly here about LD health checks, and now we're exceeding the target. People have really committed to driving that forward for our LD community and the benefits of having that regular check. So that's a real benefit. There's a description of all the new roles that are now in primary care, to meet patient need in very different ways. Not everybody needs to see a GP, and the benefits of mental health workers and social prescribers and care coordinators is hugely welcome and very beneficial. And then of course the COVID response, not only the vaccination programme, but the setting up of hubs, home visiting services, pulse oximetry, they're just really risen to the challenge. Let me know if there's any questions, Nigel, because I can't see as I'm talking. Then one of the other things that's been tricky for us to get assurance on often is medicines management. And what was really helpful to see, and you'll see in the Appendix 3, is that all the work that our medicines management colleagues undertake on behalf of the CCG, it's a big expenditure for the CCG. It's millions and millions of pounds. So it's really important that we get medicines optimisation right and the support that those professionals can give to our primary care colleagues in particular. And so the next step would be that we've asked our colleagues to come back with the assurance piece to say, now that we've seen all the projects that you're heavily involved in, where's the assurance in terms of how high quality and how safe is the services that you believe are running outside of that? What are the risks also associated with medicines management? As again, it's been a little gap for us here, but they're busy working on that. And then, of course, what we're doing, as we are with all other functions, is discussing where medicines management might best sit in terms of it's getting best value out of those specialists that we employ currently within the CCG. The risks to quality and safety that sit at QPEC, there's just a little table there, and just to say very briefly that they are all pretty stable. None of them have increased, and some are going well, such as the work on the SEND inspection after our written statement of action. And then the risks that sit with governing body, we'll just have a quick discussion about that, just so that you're cited on it. So the Hep B vaccination, this proves to be quite a knotty issue. As you know, it sat with primary care for quite some time. Whatever you think about whether it should have done or shouldn't do, it does. And primary care have done a great job with that over the years. And then NHS England decided to gift the commissioning responsibility of that, the provision of that service to secondary care. And that was mainly because it didn't always work as well as it does in the Vale of York in other parts of the country. And it's not a core service that primary care should be delivering contractually. However, the difficulty has been getting the hospital to set up a service, especially delayed through COVID, and that continues. There will be an increased cost to that, which the CCG said they would cover, but we're still waiting to get a definite date for when that will start. In the meantime, we know that patients are still being looked after in primary care, and there isn't at the minute any risk to that. We did have a situation earlier that we've described here where some people were not getting their vaccination because of that hybrid model that we had, but currently it's status quo within primary care until York Hospital can take over that service. The Healthy Child Programme changes in North Yorkshire County Council. As you know, we were concerned about some of the changes which are directly related to the reduction in the public health grant for the council. And we've stayed very close to the work streams and put forward a significant contribution to the consultation. And we are just waiting to see what will happen post-consultation. Again, that was delayed for two reasons. One, for COVID, and B, because they had such a wealth of helpful feedback that they are changing some of the intention. And as I say, we'll wait to hear. And as soon as I hear any more, we'll let you know. We have covered one of the risks described there by employing somebody to represent primary care at the child protection conferences so that nobody falls through the net. And then our biggest quality concern from a regulatory point of view at the moment is TUV, our mental health provider. As you will know, because it's in the public domain, the CQC inspected them fairly recently and found some areas where there were great concerns, particularly around risk assessment. And they are currently still undertaking inspection of some of their other services, such as forensics and community services, and they'll start a well-led inspection in the middle to end of July. So we're supporting TUV as much as we can. We've done some eyes-on visits in some of the services and didn't find anything of too concern, and we continue to support them as much as we can through this really difficult time with them. And I think that's all I really wanted to say in summary.
Great, thanks very much, Michelle. We'll open it up for comment. I was just reflecting again on the sort of plans on a page or of the PCNs and at the end of year reviews and how good those are to see. I just wondered whether we communicated those widely and to our patients and residents. So it's just something to flag up, whether we need to do a bit more engagement on that. I think they're really useful and really good to see. Yeah. Anybody want to come in on anything? That's fine. Okay. I think we're just waiting for somebody to come and give you an award. So I don't think we've got any particular questions or comments unless anybody.
Okay. Would it be helpful to just say a couple of things about what's happening in terms of the ICS development with regards to quality and safety, just so people are sighted on that?
That would be good. Thank you.
The National Quality Board have produced an interim statement about how they are designing things to gift to ICSs, and we've all had that. And what we're expecting over the next few quarters is a suite of quality metrics and toolkits to support the system. QSG, so the Quality Surveillance Group, which is at the top tier, if you like, of systems gathering intelligence about services, and things should only go to QSG where there is a concern, really. And they are changing to system quality groups, which will be led by the ICS. They're currently chaired by NHS England. So there's a specific responsibility passing over to ICSs. And the important change to the system quality group is that they will also be responsible for quality improvement, and therefore need to widen their membership to include provider collaborative representation and improvement resource, such as from the Academic Health Science Network, Improvement Academy, etc. So those are being thought through, and locally in our ICS, we've done a number of workshops already with QSG getting ready for that. They're really excited about the changes, actually, and would want providers around the table in a way that they haven't done before. So that's one thing. And then in terms of the transition arrangements, NHS England are have some programmes of work around developing ICSs, and the two new ones in part 2 of that development are quality, which I sit on, and clinical leadership, which Nigel's part of. And we are making sure that those two pieces of work collide, really, because as we always say, and it's trite to say so, but it's important, is quality is everybody's business, and there shouldn't be any distinction between clinical leadership and quality, or safety and quality, or different strategies that should have that golden thread running through it. So Nigel and I are working closely on that. So I suppose that's all I really wanted to say. The design framework, which has come out, describes the roles that are required at ICS level. 2 statutory roles, so the chief exec and the chair, and then 3 required roles, 1 who is the director of nursing, 1 who is a medical director, and 1 who is chief finance officer. And when the CEO and the chair are employed, then they will make a decision about how much wider they would want their board to be. I think people, all people have a view about whether or not you should have a people person on there, for example, and as different boards have different makeups now, I'm sure there'll be some variation between ICSs, but most certainly front and centre is a quality and a medical lead on the board, which is great. So that's all really in terms of what's happening in terms of ICS development and the transition of services for quality and safety. It's a lot of work to do, an awful lot of work to do.
Thank you. David?
Sorry, my system just bobbed out then. Can we talk about the primary care engagement and feedback survey, Nigel? Have we passed that? Sorry, I missed.
No, we can talk about it. Yeah.
Okay. Yeah, it's just a simple point, really. I mean, reading through that, and from all of our personal experience, it seems that the people that are actually on the front line, such as receptionists and triage people, often have a very, very difficult job to do. And we can see there from some of the feedback about, once I got to the doctor, it was fine, and so on. And the receptionists I know are taking quite a bit of flack from people who don't want vaccinations and so on. It just seemed to me that that's a key area that we should be addressing, that somebody should be addressing as we move forward, that the training and support for those receptionists and frontline staff, because, I don't know about you, but my friends and family, we all have these kinds of stories about how receptionists make life more difficult. And we know why, but the general public doesn't understand that. I wonder if there's some thought could be given as we move forward to new systems about actually adding adequate support and training, and even more of our kind of basic contact people, because without the contact, doesn't matter how good the service is, it's irrelevant. So that's just a theme that emerged to me as I was reading through those papers.
Yeah, I don't know, Michelle, whether you wanted to come back on that, and I don't know whether I want to bring in any of the GP colleagues on the call.
Yeah, Andrew's put in the chat, it is abuse rather than quite a bit of flack in many cases. And I think, it's a symptom of a very stressed system, and to be in the role of a receptionist where people have been trying to get through for quite some time, who are desperate to speak to clinical staff, but be that receptionist with those phone calls over and over and over as your sole responsibility must be very stressful and very difficult. And it's very wearing. And I don't know any of you have seen the YouTube video, if I die, it'll be your fault, where receptionists are talking very candidly about their everyday experiences. And yes, we know why tempers may fray and why people might get stressed, but they are people at the end of the day trying to do the best that they can. And I know for certain that, our primary care colleagues are supporting them as much as they can. So let's bring in some of our primary care colleagues.
Yeah, thanks, Michelle. And there was a really good piece on Look North last night that was Leeds practices, but also Brian McGregor from our local LMC, and also BMA rep was on. So it was a very insightful piece. Helena, do you want to come in? And I don't know whether Andrew wants to come in after that. So Helena.
Yeah, I know Sarah Forbes personally, who was the GP on North last night, and I think it was really good. I'd echo that. I just think what's really, really difficult and really sad is that there is a very significant pressure on appointments that is having a really negative effect on our communities, our population, people who totally understandably want to access care. And I just want to sort of go on the record as saying we understand that that's really, really hard. There is absolutely no doubt in our minds that that's really difficult and in some cases unacceptable. And I just then want to reiterate that we're doing absolutely everything we can with everything we've got to try and meet the demand as safely as possible. And that means that sometimes systems are different, approaches are different to how they might have been in the past. We have to apply thresholds for contact that we might not have previously applied. And it is so that we can try our very best to meet the needs of the population that we can in the best way that we can with the resource that we've got. So people are working flat out to try and get through things safely, but we totally understand that that's having a negative impact on some people who are trying to get through, who can't get an appointment. It's not acceptable. Of course, it's not to treat people badly when they can't meet that, but we get that. We get the frustration. It's just manners on all sides that are needed, really. And we wish that the rhetoric in the media and on social media too was not suggesting that we are doing nothing and that we are refusing to see people. It is simply that we cannot do it all, and it's really a very compromising position to be in as a doctor or nurse or whatever health profession or on reception. It's very compromising to feel that somebody really wants something and you can't give it to them because of the amount of other demands on the service.
Yeah, thanks, Helena. Andrew, did you want to come in?
Hello, thank you. I definitely can't put it better than Helena just put it. It was perfect, really, because it's true that I think, coming back to Michelle's point about access, access is the buzzword at the moment, and access implies there's sort of limitless capacity, and the only problem is getting people into the service, and that isn't the case. It's a capacity issue, and I think it is important, particularly coming from the LMC point of view, to make sure that I am clear as well that we get the patient perspective And I've been on the patient side recently myself, and I completely understand that frustration. So we're not looking at this in terms of like, we don't want to see people. And when people say to me, you know, it's impossible to get to see a doctor these days, I say to them, that do you not think that I would also love for you to be able to book in whenever you want to come and see me and talk? We could sit and talk for as long as you want about whatever you want. You know, we'd all love that. But we can't, and we need to be honest about the fact that we're trying to do an impossible job, really. So I think the CCG have been great in backing practices in terms of the abuse stuff, and supporting the public messaging campaigns. I still think there probably just needs to be a slightly more honest conversation about what we can and can't deliver. But I don't know how you do that without jeopardizing the CCG's responsibility to provide services. But it is really sad, and I feel sad about it as well, that we're not meeting expectations in a lot of areas, unfortunately. But yeah, thanks, Helena, because that was it was much more eloquent than I would have been.
Thanks, Andrew. Thanks, Helena. I think we're talking about what services are for and what they're not, isn't it? And that actually demand has outstripped supply at the minute across a number of sectors, or all sectors of the NHS. So where does self-care come into? Where does IT literacy come in? LinkedIn health, education, schooling. You know, I think these are the things where the long-term impacts need to be put, don't they, for this as well. So there is a lot about that. Julie, did you want to come in?
Yeah, I think we've talked about this quite a bit, and we've seen our medics in front of us almost in pieces because of the abuse that themselves and the colleagues have had, and really it's somehow we need the press to get on our side and to understand and to help us send that really strong message out there. Our GPs are there. Please don't abuse them. And actually the figures of the appointments they actually delivering might be delivering it in a different way, but they've not dropped the ball. They've continued to provide excellent care within the gift that they've got, and they will see you if that is what needs to happen next, and expedite, as we saw quite often when people have come and delivered their stories at our group, so at QPEC and the deep dive. So somehow we need that information to get out there, but the press are happy at bashing people with a stick rather than because it sounds more dramatic. But it's time that they stood tall and thought, actually, we've a duty of care to the people that we're providing information to, and that trickles down because they're damaging not only the person that's trying to get the appointment and not understanding why they're not priority, but a myriad of staff that are desperately trying to work their hardest, and that is it's not tenable. It's somehow we need to turn the ship around and say, come on.
Thank you. Helena, David, are those old hands or are those new hands?
I just wanted to come back in on something, Nigel. I just wanted to recognise that one of the outcomes of the pressure is that sort of the concept of safety and effectiveness that we really want to be good at. You know, the CQC is measuring us against. It is a challenge. So I wanted to recognise that safety does become compromised when systems are under pressure, and that wherever possible we are trying to be safe. And just touching on what Julie said, that we will do our absolute best to pick up problems, but there is a risk with demand as it is that things become less safe. And so we need to work together on that as much as possible, both in terms of being open that sometimes our systems are not as safe as they were, and we're doing our very best to manage that risk, but that there is a challenge, and certainly not as effective, because where you're waiting longer, or you're not being able to get through, or you're being diverted to 111 because there's no access at your practice, or you're being diverted to an urgent care service because that might be safer, it might not be as effective. And I think this is creating real distress for some of our patients because they feel they're being moved around a system ineffectively, and it's creating a fair degree of sort of chaotic work, because you're trying to manage things safely, but you're pushing things around in unplanned care directions, and that work often comes back to you with a whole load of dissatisfaction to boot. I just wanted to highlight that because we know that that's an issue. We're trying our best to manage that, but we don't want to pretend to our patients that we don't know that there are consequences to this way of working.
Yeah, thanks, Helena. I think it's really important to flag that, so thank you for doing that. Okay. Anything else to pick up on this bit? Michelle, I don't know whether you had any sort of reflections on that. I think it is a multifactorial issue, this of a number of years, and you know, we could go back to Sir Michael Marmot's review of what's happened over the last 10 years and over the last 20 years, and is this a culmination of things about that as well? And so is our legacy thing going forward around those principles that Sir Michael Marmot talks about for social inclusion, education, all of those type of things. So Phil, did you want to come in?
Yeah, thanks. It's always frustrating, this, isn't it, as a board or a governing body, to know what more we can do that is effective. Helena described, I can't remember the precise words, Helena, but the harm and the damage being done within our communities. And as an organisation, as a governing body, I guess the challenge for us is, well, what can we do then that goes beyond running the sort of comms media lines that we run, that makes a difference in those communities? And it's really hard to get to that, but that seems to be the sort of the test, the challenge. Those communities will probably be most affected by their own family and their own experience, and then what they see on BBC News and Look North. And we try and fill that gap in the middle, and somehow that we've got to explore ways of doing that makes a greater difference than we can at the moment. And our comms and media lines that we're running are they're really good. What we do in terms of our approach to this is as good as many organisations, if not better. But it's still. It's hard to know what difference that is making.
Yeah, Michelle, did you want to come in on that?
I think the changes to the ICS and the refocusing on population health and reducing inequalities is really the only answer to this. Those wider determinants of health and not seeing health in a box and health services in a box. If you look at, for example, the increase in ED activity for children attending A&E at the moment, and it's not all about respiratory infections. The behaviour of the adults is driving what's happening there, and that's not a criticism. That's something they've grown up with, for example, and that's what they've done themselves. So that's what they'll do with their children in some circumstances. And we mustn't forget, you know, if the lights are on in ED and it's warm and you might get a drink, that might be better than what you've got at home. And so waiting there is not an adverse thing necessarily. Digital literacy is really, really important. And I hadn't twigged myself, even long in the tooth doing this work, that there is a direct correlation between digital literacy and the development of long-term conditions. So if we don't invest really early on in technology that levels that up for our population, then people develop health needs on the back of that. And the other thing that people tell us, whether they're deprived or not, is that over 60% of people tell us they don't understand health information that's put out. So that's the challenge from a comms point of view. We can tell them as much as we like not to go, and these are the alternatives, but they don't necessarily understand that. And so that, you know, we can do better in lots and lots of areas, but not seeing it confined to what health can do and health services can do. And you know, working at place, understanding our community street by street, working with public health, working with the voluntary sector, working with housing, will start to turn that ship around, as Julie says. But it's a big task ahead.
I think what I would reflect, Phil, is the work that the CCG has done around cementing PCNs and pushing out with support for PCNs. And if you look at those plans on a page and what we've done, now, if we're thinking that we're in the last 8 months of a governing body or a CCG, what could we do to push out further into PCNs in those neighbourhoods and get that population health approach? I think that's probably what we could do. So do we need to be bolder? Do we need to be faster? Do we need to push out into those 30 to 50,000 communities? That would be a reflection from myself, because I do think the PCNs of the Vale of York CCG are ahead of some other areas. In some ways they might be behind, but I think in some areas we're really ahead. So that could be a thing that we could do. Helena?
Yeah, just to pick up on that then, I wanted to just talk, so I've been too negative, so I'm going to flip into being more positive. One of the real strengths of this last year has been the rise of the voluntary sector and the amazing community volunteer organisations and social enterprises that are just so present now because of the vaccine campaign and because of everything else and the amazing work that they've done. And I think one of the things that I would really like to highlight is that we are, as PCNs, trying to work as much as possible with those organisations who do have capacity and who have massive amounts of willing volunteers who are really engaged and totally get the problems that Michelle is flagging to do with inequalities and population health priorities. So wherever possible, whilst we might not have more staff in healthcare, whilst there might not be more money coming to deal with things, we are trying to focus on prevention of health problems and on building stronger communities and on helping our voluntary sector colleagues to do as much as they possibly can to prevent health problems happening in the first place. That doesn't solve the issue right now, but at least it looks ahead to the year or two that we've got coming. And I think that's a really, really positive thing. And we are working flat out to support those organisations to do really, really good things.
Thank you, and thanks for absolutely flagging the voluntary sector and what they can do, and an integral part of where we need to be. So thank you. Thanks for that discussion. Really, really useful. So thanks for flagging that and starting that updated. And let's see where we can go and push on with that. Okay, so if there's no other comments for that bit, I think the next bit was item 7, which was a verbal update around COVID. Now, I know that Steph was going to lead part of this, but she has sent her apologies, and I know a written report is going to be available for the minutes. But Michelle, is there anything that you wanted to pick up on this bit as well?
Yeah, just a few bits, and as I say, Steph's got major Wi-Fi problems in her village. She'll give us the detail on the vaccination programme, but just to say a few things, we are seeing an increase in cases, hence Sharon not being able to be with us twice the national average at the moment, mainly due to the rise in the Delta variant. We are seeing not necessarily a conversion into very poorly people, but part of the increase in ED attendances. And I'm sure primary care are feeling the same. The vaccination programme is now available to anybody over 18, and a big push this last weekend to do that Grab a Jab campaign nationally, and then still the promise of everybody having at least one dose over the age of 18 by the 19th of July. So phenomenal effort, and you can see from some of those year-end summaries in our PCNs how well people are doing. When you drill down to some of our priority communities, there are still some pockets of work we have to do, and we're still striving on with that with our council colleagues, especially for those who are in deprived areas or who are BAME or other harder to reach groups. So we still have work to do, and we're working hard on that. Again, vaccine availability dependent. We are seeing people who have been double vaccinated getting COVID. We've had an outbreak in one of our care homes for the first time in a few months, where it's 2 members of staff, so it counts as an outbreak because it's 2 or more. Didn't know each other outside of work, don't even work together on the same floor within that care home, and just picked up by routine testing. So certainly not out of the woods yet. And then I guess the other thing is we were talking about those rise in respiratory illnesses. People confidently saying this isn't a rise in COVID in children, because it's not, but it's the expected surge of respiratory infections which have been delayed through the usual patterns that you see of bronchiolitis earlier on in the year, popping up at unusual times. And again, that will be increasing before it gets better. And people are being asked to put in nationally their surge plans for that, because we are expecting this to get worse. We've had a meeting yesterday. I wasn't able to be there, but I've seen the summary. I don't know whether you were there, Nigel, around how we might more locally address that surge, and some opportunities that gives us to work together with our primary care colleagues to look after our under 5s especially. And as I said, we're not necessarily seeing RSV coming through, but we are seeing some very sick children with bacteremias. We're also seeing some people who perhaps could be looked after differently, but we've just had a discussion about why that's easier said than done. So that's all I really wanted to say about COVID.
Yeah, thanks, Michelle. Just to flag that there are regional discussions and more local discussions about paediatric attendances at ED and possible surge in RSV in a couple of months. So that is ongoing and very live issue. Anybody wants to come in on that bit? Andrew?
Thank you. Yeah, thanks, Michelle. So it sounds like things are, potentially going to be quite bad again. So I've just got 3 points to raise, if you don't mind, on the subject of COVID. The first one is just about the lateral flow test messaging, and the fact that it really is becoming a huge issue now that people are doing lateral flow tests when they have COVID symptoms. And I think it's just been poor national messaging, but I just wondered if the CCG had any plans to try to clear up that mess locally, to try and get the message out that you still need a PCR test if you have symptoms.
Yeah, absolutely. I'd agree with you. And one of the things we're picking up with Peter Roderick and Sharon Stoltz to do a joint piece of comms on that, you're absolutely right. It's misunderstood, the use of LFD, and it's not for those with symptoms. And of course, the symptoms are changing. What people are mainly seeing now is cough and headache and fatigue, not the ones that we originally associated with COVID, although they still exist. So the messaging is more complicated than it was to start with. But yes, we will absolutely get onto that.
Yeah, it's going to be interesting if fatigue on its own is a symptom that requires test and self-isolate. The other thing was just about PPE. So I'm aware there's been some evidence that the PPE that we've been supplied with in practice is not effective anymore against the Delta variant. Are you aware of any upcoming changes to the PPE guidance for practices?
No, interestingly, I haven't. I mean, there was the guidance that came out a few weeks ago, which made life easier for you in terms of PPE and giving you that ability to reduce the time between patients, because the PPE wasn't didn't need to be as robust. And then, of course, as things are hotting up, that might take a backward step again. And since that announcement that there is some evidence that the PPE wasn't necessarily as robust as it could be, particularly the masks is what we're talking about, for some people with significant symptoms of COVID. I haven't then seen anything which tells us that therefore you're going to be supplied with X instead of Y. So I haven't seen anything at all since then.
Thanks. And then just my final point, if it's okay, is just about, I guess it's just messaging really. And I think that there's a feeling really that COVID's over amongst quite a lot of the public. And it doesn't help when you've got a new health secretary who immediately says that they want to speed up the end of lockdown and make it irreversible, as if it's the end of a film or something. And I personally have concerns about the fact that we're going to be pushed to open things up too much. And even just looking at the fact that, you know, the PLT obviously is now going online, but there's a temptation to make that face-to-face, and then you've got all of these GPs coming together in a reasonably enclosed space. And I just wondered if there was going to be any push from the CCG to kind of look at that into, I think there's a lot of talk about bringing face-to-face meetings back and opening up face-to-face to patients. And it's looking like more and more of a bad idea, in my opinion. Is there any plans from the CCG?
So there's certainly not a push from the CCG to open up, quite the opposite, very, very cautious, even with our own staff too. And as things started to hot up again, we reversed our planned comms, if you like, for staff to start thinking about how they would operate on a phased return coming back potentially. But we bow to our public health colleagues to advise us around that. And I think an absolute cautious approach is right one. I understand human behaviour of being totally fed up with this. It's gone on a long time, and then mixed messages nationally around, you can't go to your child's, you can't have a sports day, but you can go in your hundreds and thousands to a football match. And therefore people lose faith in some of those messages or can't quite understand the rationale behind it. So we are led by what's happening with our rates and with our vaccination rates and our attendances and other bits of information. And we work very closely with our public health colleagues on that, but absolutely no push from the CCG to do something out with that. It doesn't make sense to do so. And I think professionally, we have to take that really strong line, don't we? And walk the walk and stick to the rules. We have to role model that's our job.
Brian McGregor was telling me that the BMA have now decided that, well, they've banned face-to-face meetings of more than 15 doctors at once until November, at least.
Yes, I'd heard that too. Yeah.
Thank you very much. Anyway, I'll leave you alone now.
Thanks, Andrew. And thanks, Michelle. Anything further to pick up for Michelle? No, great. And thanks, Michelle, for that. And as you outlined, the other detail will be available from Steph also in the minutes. So that's great. Thank you. Okay, so that's item number 7. So we're going to move on now to Abby and the Board Assurance Framework, and this is to receive this, and this is on page 50 of the agenda pack. So Abby, over to you, and good morning.
Morning. Yeah, so I'll just take this as documents have been read. I think in terms of just the only one to flag is in relation to concerns around TZESC with Vale and the recent CQC inspection. That's gone under the mental health slide, so it's gone under Denise's slide just because it's specific to mental health, but of course it could have sat under Michelle's quality slide. We know those issues apply to both. The new information is highlighted in a different colour on the slides, and all the risks that we've currently got, you'll see there's significantly fewer than we have had historically, are all put at the back and colour coded, and you've got the sense of direction of travel of those. Just one thing to flag that doesn't appear on the Board Assurance Framework, but that we have been directed by the auditors that we've got to put on there for the purposes of our information governance toolkit, is a risk around cyber security. So NEX have provided us with a new risk to go on F&P's risk register for cyber security. It doesn't appear on the Board Assurance Framework at the moment. It has just gone onto a risk register as of the day before yesterday. And just gives assurance about NEX having a sight on whether we've got any significant cybersecurity risks. Overall, it's scored an 8, and that's deemed to be a tolerable risk for NEX. So I think for us, we can take some assurance from that. And it's only had to go on because we have to have that risk on there to pass our data protection toolkit. So I just wanted to flag that to you. Other than that, I don't think there's anything significant that I need to draw your attention to, and the report speaks for itself.
Great, thank you, and thanks for that clear update on that. I don't know whether anybody's got any queries or questions around the board assurance framework this month. No, that's fine. Thank you very much, Abby, for coming and presenting that, and we've received that. So that means that we're now into further item number 9, and this is the annual reports and accounts. There was a report, an annual audit letter that was circulated or added separately. And this is over to you, Simon. So this is to ratify this, is that right?
Yeah, thanks, Nigel. That's right. This has already been agreed and approved by the audit committee. So Phil might want to offer his thoughts as audit chair, but nothing significant to highlight from my perspective in the annual report. The audit statement on the accounts is good. It reports a true and fair view that all the accounts have been prepared in accordance with guidance, that there is nothing to report of concern for governing body in relation to matters of going concern, regulatory aspects of how we've spent the money, or indeed on value for money. So to all intents and purposes, a clean audit report for the year. So I've nothing more to offer on the annual report, but Phil may want to come in and just give a view.
Yeah, great. Can I bring you in, Phil?
Yeah, thanks, Nigel. Yeah, I'll give my 10 pence. This is a very positive story for the CCG. The annual report and accounts spans right across the activities of the CCG. Simon and the team, not sparing his blushes, have done a fantastic job this year, because it's been inordinately more difficult to prepare the statutory accounts from a remote basis. That's been reflected in a very positive external audit report. And I'll say again that our external auditors aren't easily pleased. They don't shower organisations with praise. But underneath that, we've got our internal auditors who've, for all of their work for the last year, have awarded the CCG one of the 2 highest levels of assurance for all of the things that they've looked at. And that, in my experience, is pretty well unprecedented. So the last 2 audit committees have, within the wide-ranging remit of the committee, have had the principal task of approving first the draft and then the audited accounts and annual report. Like all CC from the.
You seem to have your internet seems to have cut out, I'm afraid, Phil. So, I think it's gone. Cut out so much that.
Sorry, I've just come back.
Okay.
Yeah, Zoom dropped me.
Yeah.
Obviously something else.
Yeah, you dropped out sort of about 2/3 of the way through. So.
Right. So I'll try again. So both internal and external audit have been very, very positive. In my experience, that's unprecedented. The audit committee, in its last 2 meetings, the principal task that we had was to look at and approve the draft and then the audited statements of accounts. We were very happy to do that. And in doing that, Julie, David and I, following the 28th of May audit committee, were very happy to be able to write to all members and staff in the CCG, thanking and congratulating them for what has been an unprecedented effort over a very difficult year. So within the ICS, I think we should be shouting this from the rooftops. This is pretty unprecedented in my view, to have such a consistently positive commentary from both internal and external auditors. I don't think we would be looking to a lot of other organisations for significant improvements in risk management and governance arrangements. It's been a really positive news story over the last couple of years, how we've improved that. Thank you.
Great, thanks, Phil, and thank you for writing. I did see that letter out to all members and all staff members of the CCG. So thank you very much for that letter. Absolutely well received, and we record our thanks to the audit committee and the finance team for the clean bill of health, and to everyone who's contributed to the annual report. So thank you very much, and thanks, Phil, for summarising that for us. Okay, so that's that bit. So our last bit today to receive is again, Simon, is the financial performance report. So this goes up to month 2. So over to you.
Thanks, Nigel. So following on from what Phil said, I mean, my advice to this governing body throughout the period of my tenure as Chief Finance Officer has been to approach our financial position realistically, so to state clearly what we think we need to do and what the financial position tells us, and to manage that closely and transparently throughout the period. Nothing will change in that regard through this last little while of the CCG's business, notwithstanding what I said earlier about the potential for lengthening the transition of how money will be managed in the future. So month 2 is the period we're reporting to this governing body. Again, I'll take the report as read. What we're describing is a small year-to-date overspend, but forecasting the first half of the year, April to September, will be on plan. However, we are starting to see a concerning increase above budget in our continuing healthcare costs, particularly around fast track and fully funded packages of care. This is no doubt connected with our continuing to support the acute sector in discharging patients as quickly as we possibly can to maintain acute sector capacity, not only to respond to the pandemic, but also the consequences of the pandemic, specifically the backlog of people waiting. This has the potential over the first 6 months of the year to be a £2 million overspend just on continuing healthcare alone. So clearly, if we think about the whole year, that would be a significant overspend. We are looking at an underspend on funded nursing care. However, most of the budget's forecasting in line with plan at this point. And again, just to reiterate, we're not changing our approach to how we forecast, control and manage our spend. Thinking about the whole year and thinking about our ability as an organisation to manage that position, which again has been our approach to discharging our financial responsibilities. We are looking at this point at a potential £1.5 million overspend. So although continuing healthcare itself might be £4 million overspent, if we did nothing, we don't expect to do nothing. We expect to have an operational action plan that we can implement to bring that back with due regard for the overall system position, not only in terms of elective activity and emergency capacity, but also the overall financial position. But we are on with producing a plan to manage that. Even once we've done that, even once we've looked at our balance sheet, we still think we've got £1.5 million of risk that we need to manage back down to break even. So we are still reporting that we will break even at month 2, but we have some actions still to identify and then implement. It is useful, however, that it's early in the year that we've picked up on this. It's also worth bearing in mind for the governing body that across the Humber Coast and Vale there is a financial risk sharing agreement now in place. which seeks to ensure that across all organisations in the NHS, that there's an overall break-even position managed. So we've got to look at our financial position in a balanced way. So it's not for us, for example, not that I'm suggesting that we would do this, but it's not for us, for example, to shut up shop on continuing healthcare. We've got to have due regard to the overall system position. It's not just about our money, although it is clearly important that we do our very best to bring that in as near to budget and break even as we can. Of the significant areas that Phil mentioned in his report earlier that are out with our allocation, so the hospital discharge programme is subject to reimbursement, as is the elective recovery programme. Just some headlines on those. The hospital discharge programme is being managed across the Health and Wellbeing Board geography. We expect to be able to manage that within budget. That's quite significantly reduced financially from last year. And again, the National Elective Recovery Programme, a £1 billion fund that was identified to support the waiting list positions and recovery of waiting list positions. Initial work is looking like that's oversubscribed by about 2 to 1. So in other words, we've managed as an NHS nationally to identify work that might cost £2 billion to achieve, but there's only £1 billion to pay for it. So we are still currently working through what that means for local financial plans, local financial flexibility, etc. And again, probably final point from me, this year is like last year, and that guidance is coming late and in a very developmental way. So we're still not absolutely clear on what's happening with hospital discharge programme, and even less clear on what's happening with the elective recovery programme. Both of those funding streams are out with our financial plan and allocation. We are halfway through half one of the year, and we've still got a good degree of uncertainty about fairly material elements of funding. That said, we managed that last year. This year is no different. We'll approach it in the same way, keeping you closely apprised of information as it becomes available to us. So work to do. We thought that we would have a harder job this year than last year. Half one of last year was money is no object. In broad summary terms, and any overspends were reimbursed. Half two was the fixed allocation and was less money than half one. Half one this year is less money again, and half two we are informed will be less money again. So as well as the comments earlier about how we are predicting we're coming to an end on the pandemic, we are seeing a ramping back up towards the old financial control regime that we were used to operating in before the pandemic hit. So lots of things coalescing at a similar time alongside that very live policy position. That's probably all I need to say at this point, Nigel.
Great, thanks, Simon. Thanks for that summary and context about where we've been, where we're going around the allocations. Anybody got any queries, anything they want to flag for Simon for that part? No, that's fine. Okay, great. So we're actually coming towards the end of our agenda. We've got through this quite quickly today, and that's the likelihood is because we haven't had the public questions and also patient stories. So we're probably on track for where we need to be. So we've got the received items that were in the pack and the minute, so that those are for information. So we will receive those. And as we said before, we're just going to confirm the date of the next meeting. So Phil, I don't know whether is there anything else from you as accountable officer at this point to add in before we close the meeting?
Thanks, Nigel. No, nothing specifically, just to say thank you to everyone for their work that's contributed to that end of year position, and look forward to continuing to work with everybody over the summer. Nothing else. Thank you.
Great, thank you. I would completely reiterate that and thank all the staff in the CCG for their continuing support and work. Thank to all the staff in health and social care that are under extreme pressure at the minute, and we understand those, and we work with you to try and alleviate all those pressures. And I think to everybody, I would just say keep safe, follow the guidelines, and please look after yourselves over the summer. Let's see where we get to in the next month or two. So thanks very much, everybody, and thanks to the members for joining today. And thank you, David, for dialing in from the Isle of Mull. So on that note, we're going to close the meeting there, and thank you.